Hello everyone, I'm Talah Nammor. I'm a fourth year medical student and I'm going to um, teach you today the autonomic nervous system. So we have to start off with knowing that the autonomic nervous system is there to maintain the homeostasis of our body. And I'm pretty sure you know what homeostasis is. Homeostasis is basically the constant level that our internal atmosphere is at. So we want to make sure that the environment inside our body is at a constant level and it's not always fluctuating. Because if you want to think of it, what does homeostasis like? What are the things that come under homeostasis? So basically our heart rate, our breathing rate, our core temperature, all of these things are essential things that we want to keep in check and keep them at a controlled level. So to basically maintain our homeostasis. And it's important to know that the autonomic nervous system is in charge of our involuntary functions, such as the things that I just mentioned, the blood pressure, heart rate, respiration, the body temperature, digestion, and reproduction. All right. And the autonomic nervous system is made up of two different systems, the parasympathetic and the sympathetic. And you have to know that one of them is there for your fight or flight. So let's say there is, as you can see in the picture, a snake that is following you. Your body needs to adapt in a way that would help you run away. So basically, your sympathetic system will help your heart rates increase so you could basically supply oxygen to your muscles faster. It will divert the blood from your GI all the way to your heart. So you have again more blood to like transfer oxygen through the muscles that are working. Your respiration will increase, so you have more oxygen in. So you have to know that the sympathetic nervous system is there for flight or fight situations, or to basically increase your blood pressure, your heart rate, your respiration, your body temperature, and so on. While the parasympathetic system is there for you to rest and digest. And as you can see here, the man is literally just sleeping. So rest and digest means that there is nothing scaring you, so you're just trying to exist. So you want the normal blood pressure, normal heart rate, normal respiration, normal everything. And because you don't need the like huge amounts of blood and oxygen to go to your heart and your muscles, your GI is going to start working and it's going to digest. All right. And it's important to know that we have each of them is made up of an efferent and an efferent component. All right. And I'm pretty sure that you know from your skeletal muscle, wait, I'll show you here. Okay. In here, you know how basically in the skeletal muscle we have an afferent, or basically the site where the thing originates from, like the nerve originates from, and then you have the efferent, or basically it's closer to the target organ. Okay, so it's important to know that we have an efferent and an efferent. For a quick overview, we just mentioned that the sympathetic is there for fight or flight, and the parasympathetic is there for rest and digest. And it's really important to know that we have a preganglionic neuron and a postganglionic neuron. So the preganglionic neuron, usually it originates from the central nervous system, okay? And when I say originate, I mean that the cell body, all right, the cell body comes from the central nervous system. And what are the components that make up the central nervous system? They're basically your brain, your brainstem, and your spinal cord. So you have to know that the preganglionic neuron, the cell body of it, okay, the cell body, it usually is found in the central nervous system. And you can see in here, the preganglionic neuron in here, it originates either from the brainstem or the sacral region of the spinal cord. So this is within the central nervous system. And the location of origin is really important because I'm pretty sure they might ask you that, okay, where do the preganglionic cell body of the parasympathetic, like where is it found? So you would say like brainstem or the sacral and the sacral region of the spinal cord. But for the sympathetic, it is usually found in the thoracolumbar part of your spine. All right. Now, the postganglionic, on the other hand, the cell body is found in the peripheral nervous system. So basically, the peripheral nervous system are all the nerves that go out of the spinal cord and away from the central nervous system. All right. Now, the preganglionic, you could think of it as the afferent or the origin of the nerve, or like the impulse, because we have two different like nerve fibers. So it's the origin of the impulse. And then the postganglionic, and the postganglionic is the one that connects with the organ eventually. All right. We usually call the organ that the nerve connects to the target organ, because this is the organ that we're targeting with our impulse. All right. So mainly both of them, both systems, the sympathetic and parasympathetic, share the same target organs, but they have different effects on them. All right. And here is another like tiny like drawing where it explains the difference between the somatic nervous system, or the nervous system that controls our skeletal muscle. And we know that the somatic nervous system is a voluntary nervous system. So basically, I will voluntarily flex my muscles, I will voluntarily move my wrist. So all of these are under the somatic nervous system, which control our skeletal muscles. But the sympathetic nervous system and the parasympathetic nervous system that come under the autonomic nervous system, they're usually there to control activities that are involuntary, like breathing, like digestion, and all of those different things that we don't actually control. Now, the sympathetic nervous system, you can see here that basically the cell body is in this is the spinal cord. So this is the, I think, ventral horn or anterior horn. We'll make sure, like moving on, but it's important to know that they are in the spinal cord, okay? And then they go all the way into the sympathetic ganglion, which is basically, it's a ganglion of nerves that is beside the spine. And then in there, they relay with the postganglionic nerve fibers that run all the way into the target organ, right? While the parasympathetic nervous system, it originates in here from the brainstem, and it can originate from the sacral region of the spine, okay, while the sympathetic is only in the thoracolumbar region. And then the preganglionic will travel all the way from the brainstem, all the way into the place beside, okay, beside the organ, and it will relay with the postganglionic, with the postganglionic nerve that will eventually basically send the impulse into the target organ. Now, one of the things that you can figure out that are different is the size or the length of the preganglionic and the postganglionic in both like sympathetic and parasympathetic. In the sympathetic, we can see that the postganglionic is like way longer than the postganglionic and the parasympathetic. And we can see that it starts away from the target organ, while in the parasympathetic, it's very close to the target organ. So this is one of the things that you can keep in mind that can help you differentiate between the sympathetic and parasympathetic. Because sympathetic, the postganglionic is away from the target organ, it's longer, while in the parasympathetic, the cell body is closer to the target organ and it's shorter, right? And another thing that can help you differentiate between the sympathetic and parasympathetic is the place of origin. As I mentioned earlier, the sympathetic, it origins from the thoracolumbar region, while the parasympathetic only origins from the brainstem or the sacral regions. And in here, you can see this more properly. So this is the sympathetic division, and you can see that it only, okay, it originates from T1 to L2, which is basically part of the thoracic and the lumbar. That's why they call it thoracolumbar. And then you could see how short the preganglionic nerves are, because they go and then they relay with the postganglionic at the basically sympathetic trunk or the paravertebral ganglia, okay? And it's called paravertebral ganglia because it's just beside the vertebra. So this is your vertebra, okay? And the paraganglionic vertebral ganglia is gonna be beside your spine. All right. Your spine is in your vertebra, the bony part of your spine. And on the other hand, the parasympathetic, you can see how it originates from the brainstem and from the sacral region of your spinal cord. So this is another important thing to keep in mind that could easily help you differentiate between the sympathetic and the parasympathetic division. Now let's go into more details of the sympathetic nervous system. So as I mentioned earlier, the sympathetic nervous system is called the thoracolumbar system. Why? Because we have the preganglionic neuron cell bodies and the lateral horn of T1 to L2. It's really important to know lateral horns. So lateral horns, I'm pretty sure they're gonna get a question where it's like, oh, where are the preganglionic neuron cell bodies located? And you have to say lateral horns, okay? And in the thoracolumbar region. And we said that it controls the response to stress or fight or flight response. Now the preganglionic sympathetic neuron, okay, we said that they are found in the lateral horns of T1 and L2. Specifically, okay, they are found in the anteromediolateral nucleus, okay, which is basically found in the lateral horns of T1, L2. This is another important thing to know. So if you want to think of the preganglionic neuron cell bodies of the sympathetic nervous system, they're located in the anteromediolateral nucleus that is found in the lateral horn. So we could think of it like, okay, lateral horn, but where is it exactly in the lateral horn? So it's basically in the middle, like intermediolateral. So it's kind of in the middle between medial and lateral. So it's intermediolateral nucleus, okay? That is found in the lateral horn of T1 to L2. Now, all the preganglionic sympathetic axons is the, basically, you know, how the cell body is inside the lateral horn. The axon is going to leave and go through the ventral roots and ventral rami, okay? So how do they, so they originate here at the intermediolateral nucleus of the lateral horn, and then they leave through the ventral roots and rami, okay? What is leaving? The axon, okay, or the nerve fibers. This is extremely important too, because you have to know the course of the nerve, all right? So it originates in the intermediolateral nucleus of the lateral horn, and then this is the cell body, it lies here, and then the axon is going to leave through the ventral roots and rami. And then they go, like this is the ventral root and rami, this area here, and then they go through the white ramus, okay, into the sympathetic trunk, okay? And the sympathetic trunk is called also the paravertebral ganglia because, as I mentioned earlier, it's usually close to the vertebra. Para means close to, like adjacent to, like, kind of, okay? So let's go through this again really fast. We have the sympathetic nervous, basically sympathetic preganglionic nerves. They originate in the intermediolateral nucleus that is found in the lateral horn, and then the axon is going to go out through the ventral root and rami into the white rami, and then it communicates with the basically, or synapse with the postganglionic cell body, okay, which is located in the paravertebral ganglia or the sympathetic trunk. And all of this take place in the thoracolumbar part of, like, from T1 to L2 and the spinal cord, all right? Now, after all of this happens, the postganglionic neuron, we said that they're located in, like, the cell bodies are located in the paravertebral ganglia or in the basically sympathetic trunk. And then the axons are going to leave, okay, through the gray communicates rami, okay, where they will join all the basically spinal nerve branches. So they can innervate the blood vessels, the sweat glands, etc. Okay, so again, we have the This is the preganglionic cell body. It's located in the anteromediolateral of the lateral horn. Okay, and then it goes. The axon is going to go through the ventral roots and rami into the white ramus communicates, where it communicates with the cell body of the postganglionic nervous postganglionic cell body. Okay, and then it's kind of like take the impulse there, and the postganglionic will send the impulse through the axon that goes through the gray communicates rami, and then it rejoins all the spinal nerves that basically that innervate the area. Okay, because we know that we have like nerves that are there for different reasons, like for sensation, for like all of those different things. All right. Now, basically, constriction of smooth muscle in the arteries, they will either elevate the blood pressure, or basically constriction of smooth muscles will elevate the blood pressure. Why? Because this is the lumen, okay? This is the lumen of the blood vessel, and this is the blood. Now, the blood is going easily through, but if it constricts, it will push the blood real fast, so it will increase the blood pressure. And this is one of the basically mechanisms where the sympathetic nervous system work by, because we know that in a fight or flight situation, we need to increase our heart rate and blood pressure, so oxygen is fastly like transported into the muscles. All right. And in here you can see the parasympathetic ganglia. Sorry, not the parasympathetic, the paravertebral ganglia. So the paravertebral, I mean, like you see, this is the vertebrae. These are the vertebrae. And then just beside it, we have the sympathetic trunk, or the paravertebral paravertebral ganglia. And in here you can see it as well. This is the sympathetic ganglion trunk. And this is kind of closer to the ribcage. And in here, we have basically the spine in the back. Okay, this is kind of like, it's the like the this one is on the back, but this one is on the other side. I don't know how to explain, but this is the sympathetic trunk. This is all you need to know, and it's the paravertebral ganglia. And in here we have the cell bodies of the postganglionic sympathetic neurons. Correct. So you can see in here that we have like kind of different, like we have A, B, C, D, okay? Or I think this is how the doctor is trying to show you that. So for B, usually the paravertebral ganglia, it goes and innervates all the smooth muscles in the chest, okay? And the glands, all of them that are in the chest. So what do we usually have? What organs we have in the chest? We have our lungs, we have our cardiac muscle, we have the conduction system, okay? And then in C, or at a like kind of lower level, we have the abdomen and pelvis. So it controls our GI. And then D is for the adrenal medulla. So the adrenal medulla, you know how we have two adrenal glands. So basically they are usually above the kidney, and the adrenal medulla is really important for your hormones. It secretes like most of our hormones, so it's really important. And in here, we're talking more about the adrenal medulla. Now, the adrenal medulla has like a kind of specific, so it kind of has a specific orientation where it does not have postganglionic. So it doesn't have a postganglionic neuron. You know how basically all the different organs, they have a preganglionic and a postganglionic. So like the course of the impulse is usually preganglionic, it relays in synapses with postganglionic, and then it goes into the organ. But the adrenal medulla is the only organ, and this is very important. I'm pretty sure that they might ask you that. So what makes it special? It's the only organ that does not have a postganglionic sympathetic innervation. It only works on a preganglionic sympathetic innervation, and specifically the medulla. All right. Why is like it kind of sounds weird, like why would this happen? It's because the adrenal medulla itself, it secretes epinephrine and norepinephrine, which are basically the hormones that help further excite the body and further stimulate the flight or fight situation, all right? So again, the adrenal medulla, it does not have a postganglionic, it only has preganglionic innervation. And why is that? Because the adrenal medulla itself, it secretes norepinephrine and epinephrine that further further stimulates the fight or flight response. All right. Now, neurotransmitters. For neurotransmitters, okay, all the preganglionic sympathetic axons, they use acetylcholine as a neurotransmitter. So everything that is close to the central nervous system, it will release acetylcholine as its neurotransmitter, or as the basically, it's like the vessel that causes the impulse to happen, all right? While the postganglionic sympathetic nervous, like neurotransmitter, the postganglionic sympathetic innervations, they usually send norepinephrine as a neurotransmitter. And we have an exception for those. Like, it's not like, okay, we say all postganglionic sympathetic axons throughout the body, but we have 3 exceptions, and they're important. Basically, they're the sweat glands, okay, and the erectile tissue, because they work by acetylcholine. I said 3, there are only 2, but yeah. So have it like as a rule in your head. Preganglionic, they secrete acetylcholine as neurotransmitters. Postganglionic, they secrete norepinephrine, and we have 2 exceptions. We have the eccrine sweat glands and the erectile tissues, which basically they respond to acetylcholine that is released by the postganglionic axons that are close to those organs. All right. Now we finished talking about the sympathetic nervous system. Now we're going to talk about the parasympathetic. We said the parasympathetic is responsible for our rest and digest. So it's there to conserve our energy, to restore our body resources. So basically we will have, the pupils will constrict, we will increase salivation, because rest and digest means that the GI is dominating this phase. So basically salivation will increase, the heart rate and the lungs will go back to their normal state, or even they might be slower, especially if you're sleeping. And then the stomach and intestines, they will start basically digesting, okay? Now the parasympathetic axons, they're not distributed to the body wall or extremities. And so the axons are not distributed. Why? Because basically, remember how we said the postganglionic axons are literally beside the target organ, and then they innervate erectile tissue and coronary arteries. Exactly. So those are the only 2 blood vessels that they innervate: the coronary arteries and the erectile tissue of the genitalia. Okay, so this is important. The sympathetic, it basically controls most of our blood vessels, but the parasympathetic, it only innervates 2, which is basically the coronary arteries and the erectile tissue of the genitalia, like blood vessels. All right. Now, as I mentioned before, the parasympathetic, they originate from the brainstem, okay, and in the brainstem, okay, either from the brainstem or the sacral region, and from the brainstem, all of our facial nerves and basically neural nerves, okay, they all originate from there, like the oculomotor, facial, glosopharyngeal, and vagus, okay, and basically we have a lot of some parasympathetic nerves, but they leave with those 4: oculomotor, facial, glosopharyngeal, and vagus. Or they're found at basically the sacral parasympathetic nucleus at S2, 3, and 4. Okay, so it's either in the brainstem and they leave with the oculomotor, the facial, the glosopharyngeal, and the vagus, or they're at the sacral region. All right, and this is where the preganglionic are situated. Remember how we said only the preganglionic are situated in the central nervous system? So yeah, and then the parasympathetic postganglionic, they're usually they're closer to the target organ. okay? So let's say the one that in here, you can see that basically this one, it's like, it controls the eye. So all of the postganglionic for the eye, the nasal, like the nasolacrimal glands, for anything, the glands here, like the parotid, submandibular, all of these, they're closer in the head, all right? And then the rest, they're closer to the organ itself. You could see this is in the heart, lung, the liver, etc. Now, it's important to know, like, okay, you see these, the heart, lung, liver, stomach, pancreas, all of these, they originate from one parasympathetic nerve, which is the vagus nerve. The vagus nerve is a very important nerve, and like in context of heart rate, in context of breathing, in context of digestion. So the vagus nerve is very, very important because it contains all the parasympathetic, all the parasympathetic ganglions for the heart, lungs, and the gastrointestinal tract. All right, and it contains the preganglionic parasympathetic, and then they go and they synapse with the postganglionic parasympathetic and the terminal ganglion. Okay, so this is another difference between basically the sympathetic and parasympathetic. In the sympathetic, we have the sympathetic trunk or the paravertebral ganglia, but in here we have two different ganglia. We have the parasympathetic ganglia in the head, and this is for basically the brainstem, the oculomotor, facial, and the glossopharyngeal. But then, like those three, any parasympathetic, what is it called? Preganglionic nerve will originate in the head, will originate from those three. And then it will go and it will synapse with parasympathetic ganglia that is found in the head. But the vagus holds basically all of the nerves that are in charge of the heart, pancreas, liver, abdomen, everything else. Not abdomen, I mean stomach. And they usually synapse. The presympathetic will go all of these, like you see all these organs. The presympathetic ganglia is always originates from the vagus, and it will go and synapse with the postganglionic parasympathetic neurons that are found in the terminal ganglia. All right, and then things like the urinary bladder, genitalia, the what is it called, the cervix, the ovaries, and the uterus. It all is like controlled by the sacral nerves. All right. Here it is. So basically, the sacral preganglion parasympathetic, they exit from basically nerves 2 through S2 through S4, but they leave the ventral rami of these nerves and they go into the pelvic splenic nerves. Okay, and then so basically they originate from the sacral preganglionic parasympathetic. They go from the SPN exit that goes usually through the nerves S2 to S4, and then they leave the ventral rami, okay, of these nerves, and then they go all together in the pelvic splenic nerve. So you see these here, you have like different ones, S2, 3, and 4. They all join to the pelvic splenic nerves, and then they go as all of them into the terminal ganglia, and then from there they basically, they all go as the like pelvic splenic nerve, and then they go to the terminal ganglia, which is beside the organ, which contains basically the postganglionic parasympathetic neurons. All right. Now, in the parasympathetic, okay, so remember how we said up here that we have basically the preganglionic is acetylcholine and the postganglionic is norepinephrine. That's only for sympathetic nervous system. But the parasympathetic nervous system, both the preganglionic and the postganglionic, okay, they're innervated by acetylcholine. So both of them, the neurotransmitters for the pre and the post is acetylcholine for the parasympathetic. And this is another thing to add to the differences between the sympathetic and parasympathetic. And the sympathetic, we have, first of all, acetylcholine, the norepinephrine, okay, but in the parasympathetic, we have acetylcholine, then acetylcholine. Now, we said that we have two exceptions in the sympathetic, which were the erectile tissue and the eccentric salivary glands. Was it salivary? I think it was sweat glands, not salivary, sweat glands, okay? These are important. So basically, if you think of it, the eccrine, sweat glands, and the erectile tissue, they kind of are like the parasympathetic because both of them are acetylcholine. So don't confuse them with parasympathetic. So if they tell you, okay, sweat glands, the preganglionic and the postganglionic nerve, the neurotransmitter is basically acetylcholine. Don't confuse it with the parasympathetic, okay? It's under the sympathetic, but it's an exception where we have acetylcholine, then acetylcholine, all right? Now, here is a comparison between both of them. So again, we have 5 things to compare them with. First of all, the place where they originate from. We know that the parasympathetic, they come from the brainstem and the sacral region, while the sympathetic, the rhacholumbar, okay? And then in the parasympathetic, we know that the preganglionic are very long, and then the postganglionic are very short, and they're super close to the target, okay? So they're super close to the target organ. But in the sympathetic, it's the opposite. The preganglionic are short, and then the postganglionic are super long and away from the target organ. Now, the parasympathetic, the ganglia is small, while the sympathetic, the ganglia is large. And if you think of it, it does make sense because if you look at this, wait. So in here, all of this is the paravertebral ganglia. While in here, the ganglia is so tiny and it's terminal beside the thing. Okay, it's like beside the organ. So the ganglia of the sympathetic, okay, is way larger than the parasympathetic. Okay. Now, the action is focal in parasympathetic, so it's like directed toward the action that we need. Like, okay, I want you to contract, it contracts, but the action is diffuse. And what is this meant? Like, okay, they're saying that it's elongated by the adrenal medulla. Now, think of it this way. Didn't we say that basically preganglionic to postganglionic, we have acetylcholine, but from postganglionic to the target organ, we have norepinephrine. And we said that the adrenal medulla, it releases norepinephrine and epinephrine through the bloodstream. So the action is diffused throughout the whole body because of the adrenal medulla action on releasing norepinephrine and epinephrine, so it will stimulate everything. But in the parasympathetic, the acetylcholine will only stimulate the target organ, okay? Is this clear? And if you have any questions, you can always like send me a message or send me an email. And then the neurotransmitters, we said preganglionic and postganglionic are acetylcholine for neurotransmitters. In the parasympathetic, while in the sympathetic, we have basically acetylcholine and norepinephrine. We have the exception of the sweat glands and the erectile tissue with acetylcholine, okay? Now, visceral afferent fibers. So basically, the visceral afferent fibers, they are the ones that show you the physiological sensation of like that are not pain, okay? So basically, they are responsible for showing us the physiological sensations other than pain that goes through the parasympathetic axons in the vagus or the pelvis splanchnic nerve. So the visceral afferent are only like associated with the parasympathetic axons that are found in the vagus, or basically the ones that are the pelvic splanchnic nerve in the sacrum, okay? Now, what are these sensations? They're usually sensations, okay, so you know how basically you cannot feel, so think of it this way. If you want to harm a person, like if you want to harm a person through their skin, like if I punch someone, I'm gonna feel pain that goes from my like arm all the way into the nervous system, and then it will like kind of like understand that, oh yeah, this action caused pain. But inside our body, we're not gonna like perceive pain the same way. So how will we like, okay, when you have your stomach hurts, how does it hurt? So usually the sensations that are like that corresponds to abdominal pain is usually like if we have this tension, okay? Like how can I explain it? So okay, so we don't have pain nerves for the organs, okay? They don't like your organ is not gonna understand that, oh, I'm in pain if you like poke it, or if you like, because it doesn't have sensory receptors, it doesn't have sensory nerves, all right? But how do the internal organs, like how do we know that, oh, there is something wrong, oh, there is like, it causes pain, like, okay, I have abdominal pain, why am I having abdominal pain? We said that basically the stomach does not have sensory nerves, but your abdominal pain is usually caused by something that is like mechanically triggering the stomach, like let's say distension. So it's really important to know that in visceral organs we do not sense pain that is caused by, like, if you poke the what is it called, the organ, because it doesn't have sensory neurons, but it will only reflect the pain if we have distension in the walls, like in the walls of the respiratory structures, gastrointestinal, and the bladder. And for the heart, if we have any changes in the blood pressure and the baroreceptors, that's when it will simulate that, oh, there is something wrong. Okay, I hope this is clear. It's kind of, so it's just that you have to know that visceral pain is not like somatic pain, or the pain that you feel on your skin. Like if I punch someone, they're gonna know that it's pain because we have sensory neurons that know that, oh, I'm in pain. But inside our organs, we don't have those sensory neurons. We have like the visceral afferent fibers, and those fibers, they only respond to this tension. Okay, so basically in our stomach, if it's extremely distended, then that's when they'll be triggered. Okay, because we don't have sensory neurons. All right, in the basically, what causes or changes in the blood pressure? Basically, the baroreceptors in the arteries, if they're overstimulated or if they're not overstimulated. Okay. So usually, as we said, the visceral pain fibers, or the the visceral afferent fibers, they accompany the sympathetic trunk. Okay, and they go from T1 to L2 to the different ones. Now it's important that, okay, you see how like visceral pain sensations, they arise from excessive receptor stimulated by distension. So they're only triggered by distension, okay? So this is the only way that our internal body like kind of understands pain, all right? And those visceral afferent fibers, they're usually pseudo-unipolar neurons that are found in the dorsal root ganglion. This is important. So what are the nerves that are found in the, or what if they say, like, if the question is like, oh, we have a, like, okay, we opened up the sympathetic trunk and we saw that there was pseudo-unipolar neurons that went all the way to the dorsal root ganglion. What are those? So those are the visceral afferent fibers, all right? So the only way our internal organs can feel the pain is by distension or by ischemia. What does ischemia mean? Ischemia means we don't have oxygen. And this is really important for MI. So basically, when you have a heart attack, why do you have a heart attack? Because part of your heart is no longer getting a good supply of oxygen. So you're going to start having chest pain because of the ischemia that happens in the heart. So that's another important thing. So for the abdomen, you can think of it as, okay, abdomen, like the intestine, the liver, the pancreas, all of these are triggered by distension or by very vigorous contraction. Like let's say suddenly your GI is just contracting so hard, then this is another like thing that would stimulate visceral pain. So it's just important to know that the somatic pain and the visceral pain are so different, and it's because of the different different stimuli that they respond to. Somatic pain can respond to heat, pressure, like all of these things, but the visceral pain, it doesn't care about all of this. It only cares about distension. Okay, it cares about excessive contraction. It cares about lack of oxygen. So in the stomach, we said distension is very important, and basically uterus. So how do you know, like sometimes you have like uterus, like your uterus hurts a lot. Okay, like if you think of like menstrual cramps are one of those things where we have basically contraction of smooth muscles in the wall. So when basically females are on their period, they feel like menstrual pain. Why is this pain there? It's because of basically the strong contractions of the smooth muscle in the uterus, okay? So you see the uterus like understands that strong contractions is pain. The cardiac muscle, if we have a lack of oxygen, then it will directly cause pain sensation. This tension in the gastrointestinal tract could also cause, what is it called, pain. And it's important that this pain is carried by pseudo-unipolar neurons that go in the dorsal root ganglia. All right, and they accompany the sympathetic nervous, um, like nervous fibers in the sympathetic trunk. All right, we have something called referred pain. Okay, so what is referred pain? Referred pain is when, okay, when let's say your stomach is distended, but you feel the pain all over your stomach region. So let's say you have your stomach hurts. It's for whatever reason, okay, because of distension, because of we have a lot of gases that causes the distension, etc. So you're gonna feel like pain all over this area, all right? Because basically the pain is not like localized. It's not like it's not pinpointed, because if you look at here, the like all the organs in the abdomen, they are innervated by the same dorsal root ganglia, by the same pseudo-unipolar neuron. Okay, so basically, if you have a pain in this region, it's gonna be like referred to the dermatome or the. Okay, I'm coming with very like new words, and I know this might seem weird, but it's usually referred to the dermatome or the corresponding to the same spinal cord level. So the dermatome, okay. So our body, you'll take this in second year. Our body is divided into like dermatomes, okay? So basically, let's say this region is innervated by C1, this region, C2, this region, C3, etc. That's not true, but like it's just an example, okay? So basically, if the pseudo-unipolar nerve comes back and it relays that, okay, we have pain in something that is in C1, let's say the eye or whatever, all of this area that is innervated by this one or the dermatome that is at the same spinal cord level, it will feel the pain. So everything that is innervated by the, let's say, this nerve that it corresponds to C1 is going to have pain. So this is why it's called referred pain. So you know how basically in a heart attack, the patient will come with pain that radiates all the way into the arm. Like you see how it goes from here all the way here, because all of this area is innervated by the same spinal cord level. So that's why the pain is going to go from this area all the way down, okay? So it's just important to know that the referred pain usually corresponds to the same spinal level, or basically it corresponds to the dermatome, okay? And it's usually dull and poorly localized. That's why, like, if a patient, most of the patients that have an MI, they present with chest pain, okay? That is basically at the left side, chest pain that goes all the way down their hand. And it's weird, like, why does it go all the way down the hand? It's just because they are innervated by the same spinal cord level, okay? Now, the doctor gave you two different syndromes to know. We have basically Horner syndrome and Hirschsprung's disease. Now, Horner syndrome, okay, it's usually, it's when we have like injury to the preganglionic or the postganglionic, like any part of the thing of the sympathetic neurons, specifically the ones that innervate the sweat glands and the blood vessels in the face and the scalp. So we have two main smooth muscles that are in the orbit, okay, and the upper eye. So in the orbit, it what is it called? It basically either contracts or relax. The muscle in the orbit, usually what happens, it relaxes or dilates the pupil, okay? And the one that is in the eyelids, it maintains the eyelid up. So basically, when you open your eyes, what maintains your upper eyelid to stay up? One of the muscles of the eye, okay? So in Horner's syndrome, we have basically the sympathetic neurons. So basically, either the preganglionic or the postganglionic are injured. So this means that we cannot dilate our what is it called? So the action of dilating our pupil, because we said that dilating our pupil is under the sympathetic, because let's say you're running away from a snake or from a lion or from whatever, you have your pupils have to be widely open so you could like register all the like sunlight to go in and you can see everything clearer. Okay, so if the sympathetic neuron systems are affected, what happens is that the pupil will constrict and it will never dilate because the nerves that usually cause it to dilate are no longer functioning. Okay, and another thing, as I said, if we're running away from a lion, from a snake, or whatever, flight and fight, our eyes have to be widely open. So even your upper eyelids have to be like retracted and they're not dropping. So this is so if basically the sympathetic function is lost, it will drop. And this is called ptosis. So ptosis means dropping of the eyelid. And then we have something else called miosis. Miosis means that the pupil is contracted. So it contracts and it does not do anything. And then we have something called anhidrosis. Anhidrosis means that the half of the face that corresponds to this sympathetic, what is it called? This sympathetic nerve is basically, it does not sweat. So you know how we like always sweat, especially if like, especially if you're running, if you're doing something, you sweat. So in this syndrome, Horner's syndrome, the sympathetic nerves that innervate the face, they're no longer working because of a lesion, because they're damaged or whatever. So what happens is we're going to have three things. So if a patient comes to the emergency department, or it comes to like a normal clinic with ptosis, miosis, and anhidrosis, the first thing you have to think of is Horner's syndrome. So ptosis means we have the pupil is ptosis means the eyelid is no longer. So basically, this is retraction of the eyelid, so it's up. This is drooping of the eyelid. So you could see it here, like this eyelid is dropping down, and the what is it called? So this is the drooping eyelid is the ptosis, and then compare, like you see this, it's like contracted, but in here it's like down. So this is the ptosis, and then we have basically the miosis, or the constriction of the pupil. Compare this pupil to this. This one is so tiny compared to this one. And lastly, we have the anhidrosis, or basically this part of the face where we have an injury, it no longer sweats. Okay, so like even memorize it for the future. You're gonna take this again like multiple times in your second and third year. Horner's syndrome, we have an injury to the sympathetic, basically neurons that innervate the face. We're gonna have ptosis, miosis, and anhidrosis. They all aslan rhyme. That's a good thing. And another disease is basically the Hirschsprung's disease. It's usually a congenital disease. So congenital means it is present from a young age because it happens, like you're born that way. And in this, it's called aganglionic megacolon. So what does it mean? So basically, one of the areas of the colon, okay, we don't have peristalsis. So the colon is distended. Because why is it distended? Because we don't have ganglionic cells. So it is usually, it's a disease it's congenital. What does congenital mean? It happens it happens from birth. So the issue is that we have the neural crest cells, they don't migrate to the place that they should migrate from. So neural crest cells are the cells like when you're a baby, not even a baby, when you're inside your like mother's womb, you're like growing. What happens is the neural crest cells, they will migrate into your, let's say, your large bowel, and then they will differentiate and give basically the terminal parasympathetic ganglia. Okay, so they will cause the formation of the postgangliotic parasympathetic neurons. Okay, so let's say we don't have this. What happens is that the colon is never gonna contract because we said that, okay, the parasympathetic is there for the digestion, is there for maintaining the body's like it's there for stimulating the digestion. So in digestion, okay, we have contraction, like that's how the way it is. So if we don't have postganglionic um, parasympathetic neurons, no contraction will be triggered, and then the patient is going to come, the baby is going to cry and cry and cry. Why? Because it's distended. It's just distended, and it doesn't contract. The baby is not gonna be able to like defecate. He's not gonna go to. Why? Because it's just like the fecal material is just gonna all be there. Okay, it will accumulate because like nothing is contracting to push them down. All right. So this is what Hirschsprung disease is. Usually the baby is gonna come, he's gonna be crying nonstop. He's not gonna go, he's not gonna defecate. All of this because the neural crest cells that usually like develop and become the parasympathetic neurons or the postganglionic parasympathetic neurons, which are usually close to the organ. It will result in distension of the area. It's never going to contract. All of the fecal material will just accumulate there. And this is going to cause the baby to cry, to be in pain, to not defecate, and so on. All right. So you can see like Horner syndrome is related to the sympathetic. So we have ptosis, meiosis, and anhydrosis. While Hirschsprung's disease is related to the parasympathetic, okay? And we won't be able to digest. We're not going to have normal digestion because we're going to have the digestion, but we're not going to defecate because it just accumulates in the sigmoid colon, you see? Like, you see how the normal one is? It's going to contract and push everything through here. But in here, it's going to contract, push everything, and then it reaches the area that doesn't have the what is it called? The postganglionic parasympathetic neurons, and everything is just going to accumulate here. It's not going to go all the way down, okay? So, yeah. Anyways, this is the end of the lecture. I hope I covered all the points. And if I confused you in any part, you could just contact me through my WhatsApp. Here's my phone number, or you can send me an email. I do prefer if you just text me on my WhatsApp because it's easier to just like chat there. And if you have any questions, you can send them there. I used Dr. Vlad's presentation, so I didn't really add any slides. And that's all. Again, if you have any questions, just text me, or if you see me in uni, you could just like stop me and ask me a question. If you want me to explain in real life anything, I'm more than happy to. And wait. I wish you all the luck.